Hi, good evening. Today we have a great discussion ahead of us on a very, very important topic. So we're going to be discussing acute pulmonary embolism and how to approach it today. First of all, my thanks to the Indian Chest Society, in particular, Dr. Amita Nene, who's put together this talk with all its participants. Dr. Sandeep Salvi, my old friend, of course. He's not old, I'm old, but we've known each other for a very long time. And Dr. Raja Dar, who is acknowledged to be the Raja of pulmonology in this country. So we have, first of all, to express our gratitude to them and to the Indian Chess Society for bringing us together for this extremely important topic. We have a great panel. I'll introduce them later when we are starting the panel discussion. But we are starting off by hearing Dr. Harjeet Dumra, great friend of mine. Again, I've known him longer than he wants to remember. He is, as you know, a distinguished pulmonologist and intensivist from Ahmedabad, land of our current Prime Minister, and very well known there for his skills in pulmonology. He's a great friend and he's a wonderful speaker. Most recently, we've sparred on a debate in Kochi, and believe me, he did a brilliant job. So I'm looking forward to hearing Dr. Harjeet Dumra today. It's very important to know all about acute pulmonary embolism because it's a condition that is sadly something associated with, when it is severe, a very high mortality rate, a high case fatality rate. Though most often it's missed because it is a very mild problem. So it can be anywhere from a very mild to a very severe problem. And the key thing is a mild pulmonary embolism, acute pulmonary embolism, may be a harbinger of a severe pulmonary embolism. We have very little Indian data. So we looked at patients over a 3-year period or a roughly 35-month period and picked up about 200 acute pulmonary embolisms. And we have similar data. I think there were about 140 cases over a 3.5-year period from Ramachandra. And from another of my institutes in Bangalore, I think they had about 200 patients over a 5-year period. So what we document is not what we are actually seeing. And autopsy data seems to show a much higher prevalence. But we'll come back to this question during the panel discussion. And first, let's listen to Dr. Harjeet talk to us, taking us through a few cases of acute PE. So, Dr. Harjeet, over to you, my friend.
Thanks, Dr. Murli, for those kind words. And believe me, that debate actually was one of the few interesting sessions I've had. And thanks to you that it was made so interesting. So going on to this particular session, as Dr. Murli just mentioned about why we want to talk about pulmonary embolism. So are my slides visible?
Yes, they are. Please go.
Okay, fine. So the reason to talk about this topic is it affects each and every one of us, those sitting in the OPD and those managing patients in the hospital and in the ICU. And hence, it's high time that we talked in depth about this particular pulmonary vascular disease, which is not commonly discussed on forums at this length. So there's usually one session on pulmonary embolism and that is it. But today we are giving almost a couple of hours to this topic and I think it's justifiable. So just to set the ball rolling, I'm going to use a case vignette to highlight some of the important points of managing acute pulmonary embolism. There are no disclosures about this particular talk. So this is my patient. This is a female who's 54 years old, has comorbidities of hypertension and obesity. BMI is very high, pretty much around 34. She's recently been diagnosed with carcinoma breast. This is December of 21. Underwent a modified radical mastectomy, which was followed by chemotherapy and radiation. Because she was being given chemotherapy, a chemo port was inserted, and this was through the right subclavian vein, as you can see here. This patient completed around 5 cycles of chemo, and following that, she started noticing facial puffiness in the morning and swelling of both the upper lips. This was initially attributed to the use of steroids or fluid retention. And initially, her general practitioner prescribed a diuretic for the same. Although she improved marginally, but again, she started complaining of dyspnea, which was primarily on exertion. Around the first week of March, around 3 months post the chemo cycles had started, she developed an episode of syncope and she was taken to the hospital. In the hospital, a comprehensive workup, including neurological and cardiac workup, was done and everything turned out to be normal. just because nothing was picked up. These were some of the investigations. A chest CT was done, which showed bilateral mild pleural effusion. Because there was no clear-cut etiology for the syncopal episode, she was kept under observation in the hospital. On the next day, this patient started having worsening in the breathlessness, and she developed acute respiratory distress, and she needed almost 6 liters of oxygen. This was in the wards. And at this juncture, obviously, we were suspecting an embolism, and a CTPA was asked for. At this stage, her vitals were a respiratory rate of 28. She was hemodynamically stable, and her saturations were around 94% on 6 liters. There was no focal deficit of any kind. Now, this was her CTPA. As you can very well see, they had filling defects in both main pulmonary arteries, and there was bilateral effusion, which was more prominent on the right side. Other important features was that around the chemo port in the SVC, there was significant thrombus load, and this was also extending to the left subclavian vein. She was having something like an SVC syndrome at this juncture. So the diagnosis at this time kept was that she has developed catheter-related thrombosis of the superior vena cava and the subclavian veins, leading to an embolism with bilateral pleural effusion, and this was in a background of carcinoma breast. Now, why is an embolism important to us? With that brief background and that case, let's go to the nitty-gritties of this subject. So why is this particular modality extremely important to all of us? Because it can cause a lot of death. So Dr. Murli was just telling you about the mortality rates in embolism, but the important aspect is that this is a preventable cause of death. And why is it important? Because half of these PEs occur in hospital or healthcare related institutions. So it is definitely something which we can work out and prevent. Another important aspect is the severity of the embolism, which causes death or maybe even morbidity, is dictated not only by the embolism size, but also on the basis of cardiopulmonary status. And this is an extremely important point. Why? Because even a small embolism in a patient who has poor cardiopulmonary reserve can lead to shock and sudden death. And hence, it is not just the size of the clot or the number of emboli you pick up, which are important. It is also the background cardiopulmonary reserve, which dictates prognosis. So if a patient presents with shock, the mortality can be as high as 25%. And if in case it's with cardiac arrest, the mortality can go up to as much as 65%. And most of these incidences happen within the first hour of presentation, bringing us to the point that you cannot prevent the first event, but we bring the patient to the hospital to prevent the second event and to improve the condition of the patient. So you will miss out on the first, but you can definitely prevent the second if you go about it in an algorithmic way, which I'm going to enumerate. Acute pulmonary embolism is not just acute consequences of embolism, it is also associated with long-term morbidity and sometimes mortality. And why is that? Because basically this can have recurrences down the line. It can affect it if it is associated with DVT, you can have a post-thrombotic syndrome. And about 5 to 10% of your patients who survive can go on to develop a CTEPH, that is chronic thromboembolic pulmonary hypertension, which itself is associated with high morbidity and mortality. Not only that, the incidence of bleeding when you treat pulmonary embolism can be extremely high. And the Spanish registry showed that the bleeding risk is even higher than the recurrence rates of venous thromboembolism. That means if you go with continued anticoagulation, extended anticoagulation beyond a particular time, you also have to keep in mind that the bleeding risk can cause more harm than treating the embolism itself. Whatever I'm going to talk to you about comes from these 3 guidelines, the EAC guidelines from 2019 and the CHEST guidelines from 2021. And I picked up this from the American Society of Hematology because my patient dealt with a cancer. And you can go through these in detail and you should be able to of what I'm telling you today from these guidelines. So when we look at an embolism, the first thing which crosses our mind is to judge the severity. And like I said, the severity is based not only on the clot size, it is also based on the cardiopulmonary reserve. And most of the times we classify these embolisms into high risk, intermediate risk, or low risk. And this is by the European Society of Cardiology. The difference being in high risk, the mortality can be as high 50%. In intermediate risk, the mortality can be as high as 15%. And in low risk, the mortality is less than 1%. Low risk and intermediate risk categories constitute the most numbers. So although the mortality is maximum with high risk embolisms, but they are the fewest which you encounter in day-to-day practice. So it always gives you a chance to treat it. It usually doesn't present with a massive onset and leads to mortality. So once you encounter an embolism, what is the first and most important step which you do in a patient who is high clinical suspicion? Well, there could be several answers to this. You could ask for a D-dimer, you could ask for a PESI score, you could ask for a CT pulmonary angio, you could do an echo. But the first thing when you suspect a pulmonary embolism and it is a high probability, the first thing you do is give a stat dose of anticoagulant. And this is mandatory. Don't think of anything else. Giving a dose of anticoagulation in a patient who does not have embolism cannot hurt him too much. But missing out on this dose can definitely worsen morbidity and also lead to mortality in occasional circumstances. So how do you go about suspecting a pulmonary embolism? And there are several scores in the literature. The Wells and the revised score are the two common ones which are used. And usually there are three levels which we look at. The low levels, the probability is around 10%. In intermediate levels, if you get them, they are around 30%. And in high probability, it might be as high as 65%. Now, whether you use the Wells score or the Geneva score, these clinical probability levels remain by and large the same. There is another score called the PERC score, where it is used in the emergency department. It also has a high probability of picking up a pulmonary embolism, and you can use the one which you are most comfortable with. The Wells score is more subjective, while the Geneva score has more objective parameters. There are no comparisons to show which one is better, but by and large, the Wells score has more specificity as compared to the Geneva score. The Geneva score has more specificity as compared to the Wells score. So once you start the algorithm, if the patient is hemodynamically stable, then the first test in a patient who has low probability, you need to look for a D-dimer. When you are suspecting with a high probability, you can bypass the D-dimer test. Why? Because in a few percentage patients, you can have an embolism in absence of elevated D-dimer. So in a high probability scenario, don't do a D-dimer test. Directly go for a CT angio, and if you confirm an embolism, you treat it. On the contrary, if the probability is low or intermediate, then a D-dimer test is asked for. And if it is negative, you can avoid doing a CTPA. And the main reason behind this is that with the availability of CT pulmonary angiographies, the number of CT pulmonary angiographies which are being done has become too far, and it's become so excessive that there is needless exposure to radiation and excessive cost on the patient. So in a low probability or intermediate probability, it is best to go with the D-dimer first, following it up with a CTPA only if the D-dimer is positive. The possibility that you might miss out on an embolism with the negative D-dimer is less than 1%. So it's a reliable test when you look at it in clinical context there. So always clinical context followed by D-dimer. Like I said, an LMWH is the way to go, but now you have options of direct oral anticoagulants. The oral formulations have become the norm, and most of us would resort to them maybe after the first 5 to 7 days. But in the first 7 days, LMWH still rule the roost, and by and large, most of us follow these guidelines where we use LMWH upfront. Enoxaparin and the dalteparin are the common ones used. You can use fondaparinux as well. Always remember the dosages, because I have seen a lot of my colleagues using suboptimal dosages when they use LMWH. So always remember the dosages. As far as oral anticoagulants are concerned, the directly acting oral anticoagulants have several advantages over warfarin. One, they are fire and forget drugs, so you don't need to monitor them. Two, they have shorter half-lives, so in case of bleeding, they get washed out faster. And three, now we have antidotes for all the oral anticoagulants, the newer oral anticoagulants, whether it is dabigatran, rivaroxaban, or apixaban. And dexamethasone alpha is recently going to be launched in India, and hence you'll have an antidote to these two drugs as well. Idarucimab has always been available, so you can reverse the effect of these drugs. Look at this part. The renal clearance is significant with all the newer drugs, and hence in patients with renal failure, you need to be cautious when using them. As far as comparison with warfarin goes, the bleeding rates for all newer oral anticoagulants is much less than warfarin, and they are non-inferior as far as efficacy goes, and this efficacy is judged by incidence of recurrent VTE or VTE-related death, and hence the newer oral anticoagulants have now become the norm. Warfarin, as far as possible, is avoided, apart from certain situations, which I'll come back to a little later. Now, there are no head-to-head comparisons amongst these directly acting oral anticoagulants, and it's best to use the data from the trials rather than extrapolate one trial data to another. So in case you are using a directly acting oral anticoagulants, the newer oral anticoagulants, then there are some preferences. So when you use an anticoagulant, there are certain case scenarios where you should not use them. You should prefer a heparin, warfarin, or low molecular weight heparin. Some of these scenarios are, if the patient has extensive DVT, it's best to go with heparin or low molecular weights. If there is high initial risk of bleeding, it's best to go with unfractionated heparin because you can always reverse it faster and it has a short half-life. If it is antiphospholipid syndrome, warfarin is the norm. Please do not use the newer oral anticoagulants because the data is inadequate. In pregnancy, warfarin and NOACs are best avoided. In patients with cancer, the efficacy of LMWH is superior, although there is now data for apixaban and rivaroxaban. I already mentioned in patients with renal failure, it is better to go with warfarin if you are using an oral anticoagulant, and it's best that the newer ones are avoided. Also, with mechanical heart valves, warfarin still rules the roost. So coming back to our patient, this patient was hemodynamically stable. We sent a couple of biomarkers, the TROP and the NT-proBNP, which should be sent with each patient of embolism. These were marginally elevated. So he was labeled as a patient of intermediate low risk, and he was started on therapeutic anticoagulation with enoxaparin. Her body weight, remember, was around 100 kgs, but she was started on enoxaparin of 0.8 milligrams subcutaneous BD. At this juncture, although we had thrombosis around the chemo port, it was still left in. By day 5, her oxygen requirements had decreased and her facial swelling also had marginally come down. But by day 6, this patient started worsening again. She started complaining of abdominal distension, she started having severe headache and vomiting. By evening, she had started showing signs of disorientation. Along with this, her respiratory distress has also worsened and her oxygen requirements had climbed to around 10 liters per minute. Now, at this juncture, obviously, with the disorientation and with the heparin, we suspected there might have been a bleed. So a CT brain was asked for. And along with this, we repeated her CT chest because as it is, she was being wheeled into the CT scan. The CT scan picked up an acute subdural hemorrhage in the occipital region posterior to the cerebellum. And this was compressing the fourth ventricle. And this led to mild to moderate obstructive hydrocephalus. And this was the reason for her disorientation and altered sensorium. As far as the venography was concerned, the thrombus in the IV SVC was pretty much the same, and now it had extended to the left subclavian vein as well, which was previously restricted to the right subclavian vein, and there was progression of the thrombus on this heparin, which was used only for a day or so. Now the question which faces us, how do you manage this patient with possible progression or recurrent venous thromboembolism on anticoagulant therapy? And again, there were several correct answers here. You remove the schemoport to help us with treating this patient. You can increase the dose of anticoagulation, or you could consider thrombolysis. However, there were 3 pertinent points in this patient. One, this was a recurrent or progression of thrombus on anticoagulation. Second, this patient had a background of cancer. And third, this patient had a catheter in situ. Now, these 3 variables obviously affect your thought process. And hence, the best modality was none of the above. So what did we do for this patient? Before going on to that, let's look at some literature regarding these particular aspects. Now, if you have recurrent venous thromboembolism, once you have already started anticoagulation, and if you are on warfarin, it is best to switch to a parenteral anticoagulant like low molecular weight heparin, and this can be given for at least a month temporarily. If the patient is already receiving an LMWH and develops a recurrent embolism, it is best to increase the dose by 1/4 to 1/3. And this is sometimes seen in patients who are obese. Now, India also has some guidelines, particularly for cancer-associated thrombosis, and these guidelines come from the Tata Memorial Hospital in Bombay. And why are they relevant? Because in patients with cancer, we have seen patients developing recurrent thrombosis on anticoagulation. And for particularly patients with cancer, you can either go for a dose escalation with anti-factor 10A monitoring if it's available. You have a possibility of adding an antiplatelet agent like aspirin to these patients, or sometimes the chemotherapy tends to cause hypercoagulable state, like bevacizumab is one of the notorious drugs which tends to cause more hypercoagulability, and hence you can change the chemotherapy in a given scenario. If you are on a DOAC, you can switch to an LMWH, but if you are on an LMWH, don't switch to a DOAC. So it's preferable to increase the dose of LMWH rather than switch it. Now, catheters in situ are common procedures which are done in the ICU, and they are commonly done for cancer patients also. And sometimes the site of the PICC line or the chemo ports can cause some issues. So it's these chemo ports, if you place them best, the distal end at the junction of the SVC and the right atrium, the chances of thrombosis are less. And always use ultrasound while putting lines, because by using guidance, you can avoid multiple punctures, and multiple punctures sometimes lead to thrombosis. Also keep in mind that the bigger the size of the catheter, the higher the risk. So smaller size of catheters, lesser the risk. Also, if there is mediastinal lymphadenopathy, there are more chances of compression. So be more cautious in these groups of patients. And this is particularly seen also if you have a femoral line in situ. So always go with basically IJVs or subclavian cannulations to avoid venous thrombosis. Now, by and large, what are the guidelines to remove the line if you get a catheter-associated thrombosis? The general consensus is, if the catheter is well positioned, if it is not infected, and if the symptoms decrease on surveillance, always try to save the line. Do not be in a hurry to remove the line, because these lines are put with a lot of effort, and cancer patients don't undergo repeated procedures, particularly like a chemo port, which is extremely important for them. And it's best that you salvage this line as far as possible. So coming back to this case, in view of the SPH, the anticoagulation was temporarily withdrawn because the bleeding was because of heparin. The patient worsened rapidly from here onwards, and her GCS reduced to 6. By now, she had become hemodynamically unstable. She ended up getting intubated and ventilated and needed high double-dose vasopressors. A fresh echo showed a dilated RARV, and her right ventricular systolic pressure had climbed to 48. Remember, the first echo was normal. Her first TROP and BNP levels were normal, or almost on the upper limit of normal, but now they were significantly elevated, and the hypotension had also led to decreased urine output, and her creatinine started climbing up. We called in the neurosurgery team, but they said that it is best to defer surgery because it might lead to further deterioration in the patient's condition. And we were not sure whether it was the embolism which was causing the hemodynamic instability, or was it the central cerebral edema causing that. So the relatives were explained about poor prognosis, and we just basically went on closely monitoring this patient, continued her on mechanical ventilation, and we instituted anti-cerebral edema measures. After 48 hours, the patient started showing some response. She initially had flexor response, and she started now responding to basic verbal commands also. And surprisingly, her vasopressor requirements also started climbing down. A surgical drainage was planned by the neurosurgery team, but because the patient was stabilizing, they said we'll wait for another day before we go forward. And hence the issue came back into our court that now, because the patient is improving, we can't just let the patient wither away. And it's best to now consider an option to treat the pulmonary embolism as well as the SVC thrombosis. So now this was a hemodynamically unstable patient. So again, the question was, how do you treat this patient who has pulmonary embolism, who is hemodynamically unstable, who has catheter-related thrombosis, and also has a leak in the brain, a subdural hemorrhage? So this was not a commonly seen case, but this was a very, very challenging case. So let's go to some literature again. And the issue is, how do you define hemodynamic instability? So when a patient presents with cardiac arrest, it's like very clear that this patient is unstable. Or if a patient has obstructive shock, means the systolic blood pressure less than 90 with signs of end organ hypoperfusion, it could be in the form of altered mental status, cold clammy skin, oliguria. All these would be classified as hemodynamically unstable. Or the patient has got no signs of hypoperfusion, but has persistent hypotension, which is longer than 15 minutes, or his blood pressure drops by greater than 40 millimeters from the baseline. Again, these are classified as hemodynamically unstable. You need to rule out arrhythmia, hypovolemia, and sepsis. Also, an important point for pulmonologists is when you're treating pulmonary embolism, if you have worsening gas exchange, so even if the other parameters look okay, but the patient has climbing oxygen requirements, the patient needs to be instituted on artificial respiratory support, that also is a sign of hemodynamic instability and needs to be treated with stepping up on the management. So this is the algorithm when you encounter hemodynamic instability. Now the patient cannot be shifted, so the bedside echo becomes the option of choice. There is no role of D-dimer here. There is no role of Dopplers right away. So on the echo, if you have RV dysfunction, then this patient has a very high likelihood of pulmonary embolism. If you can shift the patient, you can go with a CTPA. But if you cannot, and if you have a high clinical probability in a patient with shock, you can go ahead with treatment of which is thrombolysis or reperfusion. However, if you have a patient in shock, but there is no RV dysfunction, the likelihood of this being an embolism is very low, and think of alternative causes to explain the instability. Now, we resort to two investigations in this algorithm. One is the echo, and the second is the CTPA, if it is feasible. On the echo, all of you are very well aware of the findings which we encounter in pulmonary embolism, but the ones which carry the maximum short-term mortality are presence of RV dysfunction, a presence of a right to left shunt through a patent foramen ovale, presence of mobile right heart thrombi, and a TAPC of less than 16. So remember these four, because these are the high-risk patients who would end up dying if you don't treat them aggressively. As far as the CTPAs are concerned, if you can wheel this patient into the CT, then the CTPA is the best and conclusive modality to go forward. Obviously, there are some limitations like radiation exposure. If the patient is in renal failure, it is not a good choice. And we tend to overuse it because of its accessibility. But there are low rates of inconclusive result. And very importantly, if you don't pick up an embolism, it does give you an alternative diagnosis right away. The radiation issue is such that it is preferably avoided in female patients because the breast radiation exposure is pretty high with this modality. And hence, as far as possible, if you don't have a high probability and a D-dimer is negative, you should never proceed for a CTPA. So in an emergency rooms kind of scenario, if you combine a venous Doppler ultrasound of the lower limb and an echo, these two together can be very specific to pick up an embolism. And if you have a DVT in addition to an embolism, the prognosis is much worse as compared to having only an embolism. So once we are encountering embolism, the next thing is assessing severity, because severity guides the treatment. And we look at several parameters to guide us about severity. Hemodynamic instability in the form of cardiorespiratory arrest or shock or persistent hypotension is just one of them. There are several other parameters which will help you judge severity, because high severity is a direct indicator of poor prognosis. So there is something called a simplified PESI score, where you look at 6 parameters, and any positivity in any of these 6 leads to a high PESI, which carries poor prognosis. If there is high clot burden, so more than 70% perfusion deficit on the CTPA, if you have proximal DVT, if you have significant hypoxemia, significant tachycardia, poor cardiopulmonary reserve, presence of right-sided cardiac thrombus, which means a clot in transit, thrombus in the IVC or the right atrium, all these are poor prognostic markers. Now, based on all of these put together, you then construct this algorithm where you divide these patients into low risk, high risk, and intermediate risk. So what is the difference between these 3 categories? It is the mortality. The maximum mortality is with high risk, and the lowest mortality, which is less than 1%, is with the low risk. Now, high risk is easily identifiable because if you have a patient in shock, this patient is high risk, and you directly proceed for treatment of high risk pulmonary embolism. However, if the patient is hemodynamically stable, if the simplified PESI score is 0 or less than 1, that is, if there is no RV dysfunction on the echo, and if your troponin levels are negative, this patient is classified as low risk, and this patient can also be discharged if social support is available and observation can be carried out at home. So there are clear-cut guidelines about how to treat high risk and how to treat low risk. The major challenge is in the intermediate group, where depending on the presence of RV dysfunction, the presence of high PESI score of greater than 1, or elevated cardiobiomarkers, you classified it into intermediate high risk, which means a patient is hemodynamically stable, but has RV dysfunction on the echo and has elevated biomarkers and a simplified PESI score of greater than 1, or an intermediate low risk, where your PESI score is positive, but your cardiac biomarkers and RV dysfunction is absent. So these 2 categories tend to overlap a bit, and the management for them also is a little different, and I'll come back to that later during my talk. So not only the risk stratification, the treatment will also be influenced by the risk of bleeding, the extent and location of the thrombus, operator expertise, and individual patient preferences. So besides the risk stratification, we also look at some other parameters, and these are clinical parameters which all of you should look at besides the risk stratification given in the guideline. So if a patient has high bleeding risk, which you can possibly look at certain scales like the Hasbled score, and you can find out the bleeding risk, always be more cautious, and you can use non-pharmacological measures like catheter-based therapies or surgical embolectomies in this patient. You can look at the severity of the breathless, and then you can encounter a patient who is severely breathless who might need rapid symptom resolution. If the patient is hemodynamically unstable or is worsening, you need aggressive intervention. So hemodynamic stability is an important parameter. The functional status of the patient will dictate what kind of therapy you would proceed for. So if a patient is moribund, has a lot of comorbidities, is extremely old, is already bedbound, you would avoid too aggressive therapies. If the patient has cancer, then also if the life expectancy is low, it's best to avoid aggressive therapy. What about the clot characteristics? So if you have a proximal clot, you can use endovascular therapies and surgical embolectomies, which is not possible with distal clots. And if there is a clot in transit, this is an extremely high-risk patient, and you need to be aggressive in this group of patients. So not only the algorithm to define the risk, but also some other clinical parameters which will help you decide what to do. Now, once you have classified the patient as low, intermediate, and high risk, the first thing you do is give a shot of anticoagulant and then decide where to place this patient, whether this goes as an outpatient and you discharge him on oral anticoagulants, whether this comes to the floor if you take him indoors, or he goes to the ICU. And we use the HESIA criteria to decide if you want to discharge the patient. So there are 11 criteria here. Any one positive will lead to an indoor admission, and you can go through these in the guidelines, and this is very well described there in the guidelines. So coming to hemodynamic instability. So how do you manage these patients? So first and foremost, like I said, you anticoagulant, then you check for hemodynamic instability. If the patient is hemodynamically unstable, reperfusion treatment is the norm, which means thrombolysis becomes the norm. Now, if the patient is hemodynamically stable, then you distinguish between low and intermediate risk pulmonary embolism. And we look at two criteria. One is clinical signs, which are manifested in the form of PESI criteria and the HESIA criteria. And two, we look at the RV dysfunction on the CT or on the transthoracic echo. If both these are present, that is clinical signs of PE severity and RV dysfunction, then this is an intermediate category patient. You perform a troponin test. If the troponin is positive, it is an intermediate high risk. But if the trop is negative, this is an intermediate low risk. With an intermediate low risk, you can go with a ward admission. While in intermediate high risk, it's best to observe the patient in the ICU. And if everything is negative and there is no reason for hospitalization, then you go with anticoagulation alone, and you can discharge the patient if there are no positive HESIA criteria. So our patient was already in the hospital. She was on anticoagulation and she worsened. So this is a patient who has progressive worsening on anticoagulation. So this patient who was initially started on anticoagulation now becomes a candidate for rescue reperfusion. So I'll come back to what is rescue reperfusion. Basically, when we talk of reperfusion, like I said, it is thrombolysis, and thrombolysis gives you more faster benefit compared to anticoagulation alone. However, the effect is almost the same if you look at 30 days. Why? Because the anticoagulation will have the same benefit in 30 days what the thrombolytics will do in the first few days. So you should use thrombolytics judiciously and wisely. If you are talking about thrombolysis, there are two different kinds. One is the systemic, where you give it intravenously, but you can use a catheter directly placed in the pulmonary artery, which is called catheter-directed thrombolysis. And the benefit here is you can do the same benefit with a lower dose of the drug. So lower dose means lower bleeding, but almost similar benefits. If the patient cannot be thrombolized, then you can resort to surgical procedures, and these are preferably restricted to patients with high-risk pulmonary embolism. So whenever we're treating the embolism, we always look at the right ventricle, because the failure of the right ventricle is what leads to adverse prognosis. So always try and optimize the volume if the patient is hypotensive, but be worried that excessive fluid overloading can lead to RV failure, to heart failure as well. And hence it should be a judicious call about fluid loading, not more than 500 ml. The vasopressors of choice are norepinephrine. The inotrope is dobutamine. Never start dobutamine in a patient with hypotension. First, always treat it with NORED. and then add dobutamine. And worst case scenario, if nothing seems to be working for you, you can go on to ECMO. Now, the thrombolytics which we commonly use are the TPA, streptokinase, and urokinase, and the dosages are mentioned, and there are several contraindications. Hemorrhagic stroke is one of them, and our patient, like I discussed, had a hemorrhage post anticoagulation. So now thrombolytics became a difficult option for us. The greatest benefits when you use thrombolytics are within the first 48 hours of symptoms, but they can be used within 6 to 14 days of disease onset. Beyond 14 days, the benefits are maybe, I'm skeptical about the role after 14 days. So what about anticoagulation during thrombolysis? You, if possible, should discontinue the heparin prior to anticoagulation. If you have given a low molecular weight, you can still proceed for thrombolytics. Monitor the PT and APTTs prior to starting thrombolytics. Always secure your lines before starting a thrombolytic, because once you have given a thrombolytic, it's very difficult to put an arterial line and a central line. So put your lines before you give a thrombolytic. And once you have completed the thrombolytic, you can monitor the APTT and restart heparin. And unfractionated heparin in the first 24 hours is better because you can reverse that heparin if there is bleeding because of a combination of heparin and thrombolytic. Infusion of 18 units per kilogram body weight is the norm. And after the first 24 to 48 hours, you can shift to an LMWH. What about thrombolysis in intermediate high-risk patients? Remember, we discussed thrombolytics in high risk where they are the rule, the norm, the gold standard. But can we thrombolyze patients in the intermediate high-risk category? And this was a very nice article, the Pathio study published in the NEJM in 2014. And they looked at patients who were hemodynamically stable, but with right ventricular dysfunction and a positive TRO. And as you can very well see, they used tenecteplase in this study. The death was much less with tenecteplase, but the incidence of bleeding was also quite high. So they said that you should not use thrombolytics in patients with intermediate high risk upfront. But an additional finding was seen that if you use it as rescue, that if the patient has failed anticoagulation and then you institute a thrombolytic in a patient with intermediate high risk category, you still have better benefits as compared to anticoagulation. So our patients had already had an IC bleed. Rescue thrombolysis was contraindicated. So what were our options? Obviously, we were thinking of non-pharmacological therapies, but there are options with pharmacological therapies as well. What are these options? You can try low-dose thrombolytics if the risk-benefit ratio favors. And there are two studies with TPA, the MOPED study and this CHESS trial, which came out in 2010, which you looked at 50% dosage of thrombolytics, where the incidence of bleeding was much less, but the efficacy was still maintained with alteplase. So 50 milligrams works as well as 100 milligrams. You opt for this option, particularly if you have a patient who needs thrombolysis, but the bleeding risk is high. The catheter-directed interventions would still be better because the dose of thrombolytic with a catheter can further be brought down. And if thrombolytics are contraindicated, you can just go for catheter interventions without thrombolysis. And basically, which one to use would depend on the available skill and the institutional preferences, along with the clinical risks you encounter in the patient. So I'm going to skip a few slides here, but our patient was on anticoagulation. Thrombolysis was contraindicated. A decision was made to first remove the chemo port, and this was followed by a catheter-directed embolectomy because we could not use the thrombolytic. So we did a suction embolectomy of the pulmonary artery as well as the SVC, and this was followed by a balloon dilatation of the superior vena cava. And this is the balloon. This is the photograph of an IVC being dilated with the balloon. And that is how we at least achieved marginal success in treating these patients. We could also have resorted to a surgical embolectomy, but remember, this patient had a low GCS and we were almost on the point of giving up. But if you have access to a good surgeon in a given group of patients who is possibly massive embolism, where there is contraindication to thromboembolysis or there is failed thrombolysis, there is good data to show that survivals are still better than not doing this procedure. So if you have a good surgeon, you can opt for a surgical embolectomy in a patient with acute pulmonary embolism, but this is based on what skills your surgeon has and what backups you can provide. What about IVC filters? So contraindication to anticoagulation, complication of anticoagulation, or failure of anticoagulation. These are the three indications where you consider IV FITC filter, otherwise don't. So our patient tolerated the procedure well. Post-procedure, the facial swelling and the swelling in her upper limb started regressing. Gradually, her vasopressor requirements started coming down. We had a complication subsequently, which was scandidemia. She needed prolonged ventilation. We did a tracheostomy, and gradually we were able to wean off the ventilator. The neurologist had asked us to defer therapeutic anticoagulation till 4 weeks. So we gave her nothing, just waited. And eventually she was discharged with a GCS of around 10 on day 42, of 8 on day 42. Now that brings us to the duration and phases of treatment of pulmonary embolism. We usually start with a parenteral anticoagulant, like it is being shown here in the initial 7 days, followed by at least 3 months of oral anticoagulants, where you can use warfarin, or preferably now it is the DOACs which rule the roost. And beyond 3 months, you need to personalize care depending on whether a patient basically needs prolonged drugs or not. If you are using an oral anticoagulant, one of the newer ones, how to go about choosing one out of the available 3? So if you want an all oral therapies, means you want no low molecular weight heparin upfront, then the trials for apixaban and rivaroxaban did not use upfront heparin, and they were shown to be equally effective. If the patient has dyspepsia or upper GI symptoms, avoid dabigatran. Recent GI bleed, again avoid dabigatran and rivaroxaban. Apixaban is the safest with a GI bleed. If the patient has a recent coronary syndrome, there is a small signal of myocardial infarction with dabigatran, so avoid it. If the patient wants only once daily therapy, then rivaroxaban is the way to go, because you can get away with once daily therapy. And if there are unstable INRs or limited access to anticoagulation clinic, then warfarin is then the NOACs are the drug of choice. Do not use warfarin. However, if you have a low creatinine clearance, then use DOACs very, very carefully. Anything below 30, these NOACs are better avoided. You can now use NOACs or DOACs, as they are commonly called, beyond 3 months also. And there is substantial data which has come up, which shows that they are equally effective as warfarin for long-term anticoagulation use. And particularly with apixaban and rivaroxaban, you can go with a half dose. So the dose for apixaban with from up to 3 months is 5 milligram BID. You can use 2.5 BID for apixaban. And rivaroxaban, where the dose is basically post-loading 20 milligram once a day, can be reduced to 10 milligram once a day. There is always this thought about investigating our patients for hypercoagulable state in all patients of pulmonary embolism. Resist the urge to do it and use these tests widely. They are extremely expensive, so do not get them done in every patient. Particularly if you have a patient who is less than 50 and patient who has recurrent idiopathic thrombosis or a family history of thrombosis, or thrombosis in unusual vascular beds like portal vein thrombosis or cerebral vein thrombosis or hepatic vein thrombosis, you need to look at the thrombophilia profile. Otherwise, please avoid doing this in every patient where you can't explain the etiology leading to embolism. Also, with pulmonologists, I've seen there is a lot of thought about malignancy coming up as a embolism coming up as a precursor to malignancy. The incidence of malignancy in a patient with embolism down the line is usually not more than 10 to 20%. And hence, every patient should not be investigated with a PET scan. The commonest malignancy which we see leading to embolism are hematological malignancy or ovarian, pancreatic, liver, and kidney malignancy. Also, lung cancers have a high risk of thromboembolism. Think of an occult malignancy in patients with thrombosis, again, in unusual vascular beds, if the patient is clotting on anticoagulation and if the patient has non-bacterial thrombotic endocarditis. The norm is 3 months of anticoagulation for all patients. So 3 months is minimum. Beyond that, you can go depending on the need. So in patients with recurrent VT, cancer VT, and unexplained, unprovoked pulmonary embolism or proximal DVT, you might need indefinite duration of anticoagulation. And which are these patients? How do you select them? There are several scores in the literature. I've used just one, the VT predict score, and this came out very recently in the 2023 European Heart Journal. An excellent scale. It is available online, and you can just enter the data. There are around 11 parameters which you need to look at, and they give this beautiful calculated risk of embolism in after stopping anticoagulation at 3 months. And then you can decide if the recurrence risk is high, then you should continue. And they not only tell you about recurrence risk, they also tell you about the bleeding risk. And that is how you can judge which patients to give continuous anticoagulation based on the risk. And not only that, you can avoid giving anticoagulation in patients who are at high risk of bleeding, and you can opt for aspirin as well in those groups of patients. So to summarize my talk in this slide, when you encounter the patient with embolism, when you suspect it, you can use the revised Geneva score or the Wells score. Your clinical hunch is inferior to these scores. So if you go by clinical hunch and along with that you add a score to it, the chances that you will be correct go up by 10 to 15%, and there are trials to support that. So don't go by your clinical hunch. Always look at a score to judge the possibility. Followed by, if it is low or intermediate possibility, then look at a D-dimer. Follow this up with CTPS and echo and ultrasound of the lower limbs, depending on your need. Once you have documented an embolism, simultaneously you go for risk stratification, which is based on PESI scores, biomarkers, which are troponin I and BNPs, looking at RV dysfunction on the echo or on the CT. Following this up, your two main drugs are anticoagulants and thrombolytics. If you are not able to use these two drugs because of contraindications or bleeding risks, you can go with non-pharmacological measures like catheter-directed techniques or surgical embolectomies. Vena cava filter should be an exception and not the norm. When you complete your anticoagulation duration of 3 months, remember that is the time to assess risk of recurrence, and you can use certain scores which I've enumerated during my talk to decide whether a patient can justifiably be continued on anticoagulation. And now the DOACs have shown sufficient, we have sufficient data with DOACs showing equal efficacy as warfarin. And if you have high bleeding risk with DOACs on the predictor, you can go with aspirin as well. Last but not the least, managing pulmonary embolism is a multimodality care. It not only involves a pulmonologist, but you need an intensivist, a vascular surgeon, a cardiac surgeon. You need your cardiology colleagues and an emergency medicine team to help you out, which constitutes the pulmonary embolism response team or a PERT team. Several centers in India have established a PERT team, which is called on as soon as there is a suspicion of embolism, and you can get to this team in your hospitals as well. And it is best to make this team because this disease can be beautifully treated and reversed if picked up early. My final word is always think of DVT prophylaxis in hospitalized patients, because this is the single most important intervention which can prevent DVT and embolism. I thank you for a patient listening, and I'll be open to questions during the panel discussion. Thank you.
Thank you, Dr. Harjeet Dumra. That was brilliant. Dr. Amita Nene instructed me that I should praise the talk highly. I don't need her instruction. This was absolutely brilliant. Thoroughly enjoyed every bit of it. And I really think you left us with nothing to discuss because you covered everything.
Better it is. But I think the audience is going to guide us as to how much they understood. So if the audience has a lot of questions, I didn't do my job well.
So we will go on to the panel discussion because we have an absolutely brilliant panel here. I don't need introduction. Dr. Balmukesh was actually asked to introduce me, but
Doctor, for the sake of completion, let me introduce Dr. Murali Mohan, and he is the Senior Consultant and Academic Director at the Department of Internal Medicine and Pulmonology of Narayana Health, Mazumdar Shah Medical Center, Bangalore. And we always look forward to Dr. Murali Mohan whenever he gives a talk in webinars or conference, because we have so much to learn from him. And his area of interest is pulmonary vascular disease, and it's apt that he is moderating this session.
Thank you so much, Dr. Bala. We have, and I'm going to introduce them in the order in which they sent me their introductions. All of them, of course, are well known, but I think it's just right to spend a minute or two introducing each one of them. Dr. Rakhi Khanduri, of course, is the Professor and Head Department of Medicine at the Swami Rama Himalayan University, a university that has come of great prominence, especially in the recent years. She is MD Respiratory Medicine from KGMU, has multiple diplomas, both Indian and abroad, and a lot of presentations in national and international conferences, and over 50 papers in index journals. And her area of interest is ILD, TB, asthma, and COPD. Our next pulmonologist returning the compliment to Dr. Balmugesh and to get praise from him. He's currently the professor and head of the department at one of the most prestigious institutions in the world, the Christian Medical College. He heads the Department of Pulmonary Medicine there and was earlier, a few years ago, in the UK, in the Lancashire Teaching Hospitals, one of the most beautiful parts of the United Kingdom, holds multiple memberships and fellowships, and of course has been awarded the KGR Murthy Oration, as well as the ICMR and the Kamal Satbir Oration. Those of you who know, KGR Murthy was one of the doyens of our profession, and the KGR Murthy Oration is one of the most prestigious orations. Our next speaker, our next panelist, my apologies, Dr. Preeti Sharma, is a senior consultant pulmonologist, critical care and ICU chief at the Meher Super Speciality Hospital, and runs her own clinic called the Breathe Easy Clinic in Mohali. She's from Chandigarh, has an IDTC CM from the Fortis Hospital, Mohali, and like the others, is a very well-known, frequently invited speaker at conferences and has made presentations at international conferences also. Her areas of interest, of course, are airways disease and critical care. And of course, Dr. Swapnil Kulkarni, for anybody who's a part of CCI also knows him well, who's part of ICS also knows him very well. He is a consultant and director of the Birth and Breath Clinics in Pune. And my favorite city after Bangalore is Pune. So lovely to have you all here. I've already introduced, of course, Dr. Harjeet Dumra. So we'll go straight on to the questions that we have for them. And I'll be starting with Dr. Raki. Dr. Raki, yes. How often do you see acute pulmonary embolism in your practice?
Sir, acute pulmonary embolism with the classical presentation, they usually present less to OPD, but more to the emergency settings. And these patients, actually, since they are less diagnosed because we suspect them less. Like, for example, we have COPD exacerbations coming to our OPDs, but we do not suspect them that these exacerbations are due to pulmonary embolism. They might be due to pulmonary embolism in about 10% of cases, but still we do not think like that. Pulmonary embolism is more picked up in our IPD patients, like in patients who are with us or who are admitted with other our colleagues. So they are picked up more when they are there, or in the emergency departments. Though they are there, but still they are picked up less by us.
Thank you. So that's, I think, two important messages. Where you look for it is very important. They often occur to us only when we are seeing ICU patients, but you should pick it up in the wards also. And Dr. Dumra ended with that, how the importance of DVT prophylaxis in patients who are admitted to medical wards. In the ICU, it happens automatically. People, the question is asked, why are you not anticoagulating this patient prophylactically? But in the wards, this is often missed. So we have a VT prediction table, much like the one Dr. Dumra showed us, to decide whether a person should or should not have anticoagulation at admission. So I'd recommend that everybody use one of these things like the VT predict score and decide what is the chances of anticoagulation being needed for this patient, of course, putting in the bleeding risk also. Our next speaker, our next panelist I'm going to is Dr. Swapnil Kulkarni. Dr. Kulkarni, what are the typical presentations of an acute pulmonary embolism? What are the not to be missed symptoms and signs?
Yeah, hello, sir. Thank you. So I'll be very crisp in answering because there are multiple questions which are coming. So clinical examination is very much important. So we can have a classical triad, something known as classical triad for PE, which is dyspnea, which is unexplained, chest pain, particularly pleuritic type of chest pain, and hemoptysis. So this is known as classical triad of PE, which may not be found in all cases, but this can lead to suspicion. And there's one symptom which is unusual, not very common, but can lead to higher suspicion, which is syncope. So syncope can lead to higher suspicion in case of pulmonary embolism. We can have signs also on clinical examination like that of tachypnea, tachycardia. Patient can have hypotension or shock. hypoxemia, usually refractory hypoxemia, is classically seen with pulmonary embolism, and signs of DVT, that is unilateral leg swelling, tenderness, calf tenderness, etc. So these are few signs and symptoms which should arouse suspicion of pulmonary embolism.
Absolutely. That's, nice, crisply put. And of course, to add to that, if you have a high risk situation, a patient who has risk factors, then suspect it even more strongly. Somebody with an underlying cancer, as Dr. Dumra showed us, somebody who's been bedridden for a few days. Next to our hospital, or now attached to our hospital, is an orthopedic center. So in a person who's had, pelvic surgery, for example, in such patients, any one of these symptoms will immediately raise suspicion that you may be dealing with a pulmonary embolism. So in the background, what is the risk factors and what are the symptoms the patients present with, or the signs of it that you pick up on examination? Extremely important. Thanks, Dr. Swapnil. Dr. Dumra referred to the PERC rule-out criteria to rule out pulmonary embolism. So what is your chance that you'll pick up? How often do you use the PERC criteria, Dr. Preeti?
Yeah, thank you, sir. The PERC criteria, as the name itself suggests, it's a pulmonary embolism rule-out criteria. It's a fantastic tool to prevent the overuse of the diagnostic test, specifically in patients who have low clinical probability of PE. If we use the 8 criteria, that is age less than 50 years, there is no tachycardia, heart rate less than 100 per minute, saturations are more than 94%, there is no history of any hemopsis, there is no history of any underlying cancer, there is no history of any trauma or surgery, or there is no lower limb calf tenderness is there, or no hormonal use. If the patient meets all these criteria along with the low clinical probability, we can safely rule out the pulmonary embolism, and we do not have to undergo any kind of diagnostic tests which are being used very frequently these days. So I would really prefer, and I prefer in my practice, to use this to rule out pulmonary embolism. It's a fantastic tool.
So the important thing, of course, is even if one of those criteria is present, then don't rule out pulmonary embolism. Extremely, extremely important. And of course, in pregnancy, it's very doubtful if the PERC criteria will apply. I think we need to be careful in the pregnancy situation. And I would say, when in doubt, think again, should you really investigate this patient? And I think Dr. Dumra has already spoken about, how you have a higher suspicion and what you do when you have a high suspicion, when you have a lower index of suspicion. And I think he made a very, very important comment. While we always have gut feelings, the scores, either the simplified Geneva or the Geneva score or the Wells score, the modified Wells score, use them because they infinitely improve your ability to predict a pulmonary embolism. I'm going to go to Dr. Balmukesh for exactly that. What is your experience of using the Wells and Geneva score?
So one of our consultants, Dr. Shonak, some time back did a prospective analysis of 127 patients of proven pulmonary embolism. And she found out that the positive predictive value, negative predictive value of modified Wells score and revised Geneva score are almost the same. The area under the ROC curves for the two models were also same and not statistically different. So whatever is available, it is a score you are able to get hold of. You can use it. Well, is it Geneva or Wells score? You can use them. So there is no need to differentiate between these two.
Thank you. Dr. Dumra, I'm going to come to you on this one. Again, this is a repetition of what you said, but I want you to tell us what is the role of the D-dimer in screening, because I feel it's often misused, it's unnecessarily used, and long delays occur while people are waiting for the D-dimer result. So can you clarify a little more?
So
it will be mostly a repetition.
What I do in my clinical practice, and maybe the guidelines are a little complex to understand, but let's simplify this. So as a rule of thumb, in any patient who is already hospitalized, the D-dimer has very low value because you can have several false positives in a hospitalized patient. Okay, if a patient is coming from the community, there could be a way to screen these patients with a D-dimer because they don't have other comorbidities which could lead to high D-dimers. But in a hospitalized patient, there are so many risk factors that a D-dimer is bound to be positive. So usually this particular step in the algorithm can be bypassed in a patient where you already suspect the embolism. because you are looking at patients with clinical suspect. You always are in context. So if you have a high suspicion in a hospitalized patient, there is no role of a D-dimer there because it will be invariably positive. Then you directly go with this thing. Now, in case you are resorting to a D-dimer, if you are PGs, if you are starting off in practice, you want to follow the algorithm. So you do your clinical context, you do a D-dimer. If you add the D-dimer to the Geneva or Wells score, the predictive value of a negative possibility gets even higher. So D-dimer plus a negative Geneva or Wells score is even more valuable. Lastly, always remember that the D-dimers can change with age. So the cutoffs can be different with different ages. So once you cross 50, always remember to change the cutoff level, because just by going by the age-adjusted D-dimer, the incidence of negative CTPA angiograms goes up by 30%. So just by changing that, you can avoid 30% excessive CTPAs. So look at age-adjusted D-dimers. These were a few things which I didn't mention in the talk.
So all extremely important points. And of course, one of the things that we often end up doing is if a person has a negative D-dimer, that is, it's lower than the cutoff value. So always remember, check with your lab what the cutoff value is, and also use an age-adjusted D-dimer, as Dr. Harjeet just told you. If it is less than that, remember also that apart from the false positive D-dimers, there can be false negative D-dimers. Okay, and in about 15% of cases, the D-dimer can be falsely negative. So if you have a high suspicion, please do not waste time doing a D-dimer. Go straight to the imaging of choice. To save time, I'm going to go straight to Dr. Raki. Dr. Raki, do you always ask for a Doppler scan of the leg or arm veins when suspecting pulmonary embolism? Or do you think, I know there's a pulmonary embolism, I don't need to do a do a Doppler?
So I if the patient is having high risk of pulmonary embolism, getting a Doppler scan to will and it is very easily available also. It will confirm our diagnosis. We do not need to go for a CTPA to confirm a diagnosis and start the treatment. So if we are having high probability of pulmonary embolism along with a Doppler scan, and that too a proximal vein, if it is positive, then chances of pulmonary embolism is high likely, and we can directly go to for the treatment. Calf, distal, the calf veins, they are not that likely to cause pulmonary embolism. Similarly, the upper limb veins, they also do not cause that much of pulmonary, very rare to cause pulmonary embolism. Proximal pelvic veins, and they are more having chances of having pulmonary embolism. So we can go for that. It is easily available. We can do it bedside. So, and we can start the treatment for the patient.
So I think Dr. Harjeet Dubra made this point. If you suspect it, give a shot of the choice of anticoagulant, whatever anticoagulant you're choosing, while you're waiting to investigate. Don't waste that valuable time. And I think the other point about Doppler scans that I just asked you, again, depends on where you are. If you can get a CT pulmonary angiogram very quickly, and we can get it within, 15 or 20 minutes, we move the patient down. For example, stroke units can do it absolutely immediately, and that's what we are able to do. We are able to get CTPAs immediately, far more quickly than we can get a Doppler scan, unless you have a very well-trained emergency medicine team who will do it for you. And as you said, you can often miss, very proximal iliac vein thrombi by waiting for a Doppler. So if it's obvious, do the Doppler and start the treatment immediately. And then you can confirm it later if you want with a CT pulmonary angiogram. And again, in pregnant people, you're trying to avoid a CTPA. I think a Doppler scan is very useful in such patients. Going to Dr. Swapnil. Dr. Swapnil, I think Dr. Harjeet has already emphatically spoken about thrombophilia workup in patients with acute PE. Do you do these? And if you do these, when do you do them?
No. So first, no, it is not required or not advisable in all patients. Why? Because first, they are really very expensive. Second, presence of thrombus plus treatment given in the form of anticoagulants can interfere with the results of the test. There are many thrombophilias, hereditary plus acquired. Many of them does not have any particular test to diagnose. And fourth, single thrombophilic defect have very low probability or low predictive value, and anticoagulation management based on it or the duration based on it have not been shown to reduce the VT recurrence. So it is not done in all patients, but yes, subgroup, as Dr. Dumras has said, there are few subgroups where family history of recurrent thrombosis, or thrombosis at unusual locations. In such cases, it can be done, but the timing is very important. One should not be on anticoagulants for at least 3 to 4 weeks prior to that testing.
Absolutely. So important. Do not send it as soon as the patient has a clot. Do not send it when you've already started anticoagulation. Wait for close to a month after you've stopped it before you consider doing it, if you are considering doing it. And if a patient has a provoked VTE, I don't think there's any point in sending a thrombophilia profile, unless a person has a recurrent VTE and you're really confused. Another group we sometimes do the thrombophilia testing is patients who have both arterial and venous thrombi. So they seem to have multiple problems, and then maybe you can test them. But as Dr. Swapnil said, extremely important that you recognize that there are false positives and false negatives with this also. So don't go by thrombophilia profile, extremely expensive and perhaps better avoided. And I always take the counsel from my hematology colleagues. That's another group we involve during our care of our patients with pulmonary embolic disease, especially when we're managing APLA syndromes and so on. So going to the APLA syndrome next, Dr. Preeti, how common is the APLA syndrome in your practice with patients with pulmonary embolic disease?
APLA syndrome, as we know of, it's also called as lupus anticoagulant syndrome or anticardiolipin syndrome, which is basically characterized by obstetric morbidity, and it can be because of the arterial or venous thrombosis of the tissue and organ. So it is seen very rarely, and we see it in like 5 cases per lakh persons per year is the incidence which is documented. And this is basically causing, in cases of venous thromboembolism, almost this is the commonest manifestation of APLA syndrome, and 10% of the cases have positive APLA antibodies, which we have seen. The only problem is it causes almost 14% of the strokes and MIs, as well as the very important 9% causes of pregnancy losses, that is within 10 weeks. So there we see it still, it's not a very common disease, it's a rare kind of a syndrome which we see, as we already emphasized that only in some people where we have familial and these things, then we should screen for APLA syndrome and not normally go for this.
So a couple of other clues to the APLA syndrome, apart from what Dr. Preeti mentioned, is if a person has chronic thromboembolic disease, much more likely to be APLA. For example, your protein C proteinase don't very often lead to chronic thromboembolic disease. It's the APLA that leads to that. The second clue very often is if you have difficulty getting an INR under control, it's swinging around wildly. So once it's 9, the other day it's 1.5, strongly suspect you're dealing with APLA. And of course, it's important because the DOACs or NOACs have not been shown to be effective in APLA syndromes. So if you have a patient who's on a NOAC and you suspect APLA syndrome, this is a group you should probably consider switching to a VKA or a low molecular weight heparin. Those are the groups you really think it's extremely important to identify the APLA syndrome, but it's rare. It's not that common. So don't go looking for it, doing the investigation every time. False positive APLAs are also very well described. My next question goes to, this again is something that, often comes up in practice, Dr. Bala, the homocysteine levels. How often is a homocysteine level something you look for and act on when you find a high homocysteine?
So this used to be a little controversial area. When you talk about high homocysteine level, there are 2 aspects. One is homocystinuria and severe hyperhomocystinemia, which is a autosomal recessive condition. It's diagnosed in childhood. Children have developmental delay, orphanoid phases, osteoporosis, a lot of congenital defects, and they have a high incidence of thromboembolic disease and premature atherosclerosis. What we usually come across is in adults, a mild elevation of homocysteine levels, and earlier studies have shown that there is twofold increase in risk of venous thromboembolism. However, further studies, large population-based studies have shown that when confounding variables are taken into account, this mild elevation of homocysteine is not proven to have increased risk of venous thromboembolism. So, and also treating a mildly increased level with the vitamins, folic acid, pyridoxine, B12 have not been shown to reduce the risk of subsequent thromboembolism. So as of now, we don't have solid evidence to recommend that we should screen for homocysteine levels in adult patients with venous thromboembolism.
Absolutely. And of course, one of the other, this is an open question to everybody. We know there is an association between B12 and homocysteine levels. And, very often we find B12 levels are low. But I've been noticing a lot of low B12 levels, and this is completely outside this topic, post-COVID. Is this something you all have been observing? And I have not found any explanation for it, but I'm finding a lot more low B12s in the recent past than, post-COVID than I used to see before. Anybody has any opinion on this?
Yeah,
Most of the
so
patients whom we advise, they are coming with low B12 levels, and especially more vitamin D also. D3 levels are also very low in each and every patient.
And they are
Absolutely.
complaining with chronic fatigue-like syndrome, like they are having body aches every time. Papers, and usually when we get this investigated, they are found to be low, and when we give them supplements, they become better. So there is something which is coming up post-COVID.
I honestly don't know what it is, but it's worth exploring. Sorry, that was a digression, which I don't think I may be permitted as the moderator. Dr. Harjit, I'm going to skip your next question because I think we've already answered it. The role of, what happens to the thrombophilia workup if a person is already anticoagulated. But I think it's important we emphasize, don't do it when a person is on anticoagulation, really.
So just one.
There are some you can do. Yeah, please go ahead. Yeah.
So just because there are certain tests which are not affected by heparin. So if you are suspecting an APLA, you can still do a antiphospholipid antibody and a GP and a glycoprotein antibody, because those two antibodies are not affected by heparin. You can't do a lupus anticoagulant. So in that subset, if you are already on heparin, but you have a strong suspicion of APLA, you can still do these two tests.
Absolutely. But be careful that your APLA levels are, the cutoffs are quite high. Don't accept something which is just slightly above the upper limit of normal.
Double the upper limit to make it clinically relevant.
And with a good preclinical test probability.
Always.
That's also important.
Always.
And if possible, reconfirm it later. Because again, that's very
12
important.
weeks down the line.
Yes. So thank you. That's, very useful. If a person has a thrombophilia profile, Dr. Raki, would you anticoagulate for their whole life?
Sir, depending upon the patients who are having thrombophilia, as well as and they are having history of recurrent VTs, thromboembolism in the families, thromboembolism at unusual sites. So these patients, they do require anticoagulation throughout life, especially in patients with APLA, patients who are having factor V laden mutations, patients who are having thrombin deficiencies, antithrombin deficiencies. But there needs to be having homozygous mutations for them to give lifelong. Patients with which we diagnose, but they're diagnosed very rarely, like having heterozygous mutations, they might not require lifelong and anticoagulation, but others they do, yes, require.
Great. Thank you so much. I think that is very clear. Some require it, some don't, and base it on either a homozygous state or recurrent PEs or very complicated PE, thrombosis in other areas. Dr. Swapnil, when you have a patient, you have a high suspicion of an acute PE, what is your initial imaging modality of choice?
So since it is the suspicion is high, you can skip D-dimer and directly proceed for the imaging. For imaging, either VQ scan or CT pulmonary angiography are the two imaging modalities which have got good sensitivity and specificity. VQ scan can be a first choice if it is available. The chest X-ray is normal. There is renal dysfunction, which is actually contraindication for the contrast administration. And when we don't want to see or we don't want to rule out any other pulmonary pathology, then in such cases, VQ scan can be done, and it can be a first choice. And CT pulmonary angiography can be first choice whenever VQ scan, wherever VQ scan is not available, wherever we get abnormalities on chest X-ray, whenever a patient is having structural lung diseases, or we alternative diagnosis we are suspecting. In such cases, we can go ahead with CT pulmonary angiography.
Absolutely. So, if I have to say it in one sentence, there's a lot more details that Dr. Swapnil has given you. If your chest X-ray initially looks normal, your VQ scan is very helpful because it's not going to be confounded by multiple other problems. If your chest X-ray looks abnormal or your examination suggests underlying structural lung disease, then a CTP is more useful. Confounding factors are less, and you may get an alternate diagnosis. So that, is very brief. Of course, the other things are very important that Dr. Swapnil mentioned. I'm going to go to Dr. Bala for this next question. So you've done a CT pulmonary angiogram, and it's been reported as normal. You've taken a look. It doesn't look like PE. Would you still do a VQ scan to rule out pulmonary embolism if your suspicion is high?
Usually, after doing a VQ scan, if it is inconclusive of an intermediate probability, we go for a CTPA, but not the other way around, because CTPA missing a pulmonary embolism, significant pulmonary embolism is less than 1%, unless there is a lot of movement artifacts and the arteries were not opacified. It doesn't, a good quality CTPA never misses a clinically relevant pulmonary embolism. So we usually don't go back to VQ scan.
So if you looked at the old literature, they said the VQ scan has a much higher sensitivity and specificity than a CT pulmonary angiogram. But I think all these studies came out about 20 years ago. If you look at the modern CT pulmonary angiogram, it's got every bit as high a sensitivity and specificity. In fact, the problem with CT pulmonary angiograms is sometimes it will pick up small clots which are clinically not relevant. And then you have to worry, should I really treat this person or not? Yeah, that's a greater problem. So completely agree with you. There's no point in doing it the other way. And I'm going to go to Dr. Harjeet. He's already taken us through this, but I want you to take us again through it because risk stratification of an acute pulmonary embolism is extremely important. So we've made a diagnosis of acute PE, and we have to decide what to do next. So can you take us through the steps of risk stratification, please?
So to elaborate that slide, the first thing obviously is whether the patient is in shock or not. And these are basic things, anyone can look at these. So shock or not, that is the first and the most important parameter. If the patient is in shock, this is a clear-cut case of high risk pulmonary embolism, poor prognosis if not treated aggressively and upfront. Now, unless and until you have some other reason to suspect shock, by and large, at this juncture, all you need to do is check with an echo for RV dysfunction. Most of the times, a patient in shock cannot be wheeled into the CTPA. And there are two modalities which you can use and which are coming up. So we have been experimenting with these modalities because these patients can't be wheeled into the CT. I think Dr. Rakhi already mentioned, or Dr. Preeti mentioned about the lower limb Doppler, which can always be used as a surrogate marker of PE if the patient is in shock with a DVT. But apart from that, one, you can, if you still have some doubt of the RV dysfunction not being related to an embolism, why that happens in the pulmonary world is because a lot of your patients are COPD and some of your patients might be ILD. And some of these patients will have background of pulmonary hypertension, which can lead to RV dilatation, which might compound your clinical judgment in an acute scenario. So in that subgroup, you can go with the transesophageal echo. If you have a good cardiologist, these patients might be unstable to undergo it. If these patients are intubated, for example, there is this nice article which I went through where you can use an EBUS to go to the esophagus, to go to the carina, and you can screen these patients in the left main bronchus for a major pulmonary artery embolism. This is an added use of the EBUS if your patient is intubated. This is in case you don't want to start thrombolytic agent where you have a high clinical suspicion. These are alternative ways to come to that conclusion. If the patient basically is hemodynamic stable, then once you give your first shot, you have the luxury of investigating this patient. So you can first send a D-dimer, wait for the report. If it is negative, in a low probability, it rules out. If it is positive, then you definitely look at the clinical probability. If the probability is high and you have a positive D-dimer, then you next look for a tropi and a BNP. Simultaneously, you are looking at an echo. So you are looking at three major things: a troponin I, a BNP level, and signs of RV dysfunction on the echo. If all these three are positive, but the patient is hemodynamically stable, he goes into the intermediate category. And if none of these are positive, but the patient has an embolism, this goes into the low risk category. So like I told you, low and high risk are easy to manage. The intermediate category, then you need to subclassify depending on what parameters you pick up. The simplified PESI is also added up, but it's just that there are too many scoring systems in these guidelines. And you can't just keep on doing them every now and then. So maybe clinical judgment will help you substitute some of these scoring systems.
Absolutely. So clinical suspicion, biomarkers, echo. We use those three to decide whether a person is high, intermediate, or low risk. And more importantly, intermediate high, intermediate low. That categorization is extremely, extremely important. And of course, the Americans use the term massive, submassive, and mild. But I think we should stick to and I think that this is actually a better classification: high risk, intermediate high, intermediate low, and low risk. So we've already gone through that. And I think, Dr. Preeti, I was going to ask you about the echocardiogram, but I think, I think Dr. Harjeet has already taken us through that. So remember that sometimes a good echo technician or cardiologist can actually pick up, even on a transthoracic echo, clots within the major pulmonary arteries, but it doesn't rule it out. Okay? So let's go on to the next. You've got a person who's got a massive pulmonary embolism, a high-risk pulmonary embolism, Dr. Raki. What's your next step?
Sir, when the patient is having like high risk or massive pulmonary embolism, it means that he is having hemodynamically, he's compromised, and there is RV dysfunction, impaired RV function. So most important is that we have to first maintain his hemodynamics. Like, first of all, it is necessary that usually these patients are hypoxic. So first of all, like, proper oxygenation is must. That could be given either by high flow nasal cannula also if the requirement is very high. Preferably, we should not intubate these patients because that will further causes like a decrease in the blood pressure of such patients. They are already in shock. And while we need to resuscitate these patients also, but not too much with fluids. We have to be cautious. Only up to 500 ml we can give, and then we have to be cautious about giving further fluids. And then we should shift to the like vasopressor, as Dr. Harjeet said, that noradrenaline is a very good vasopressor which can be given. And we should start with the anticoagulation therapy in these patients. And we should also, if the patients like they are in shock, we can start with the parenteral the thrombolytics in these patients, because as we like, if we do it early, then there are high chances of decreasing the mortality of these patients. So systemic parenteral thrombolytic therapies needs to be given as soon as possible, along with maintaining the ABC of the ABC of the patient, the airway, breathing, and circulation.
Absolutely. Don't forget ABCs. I think that point is very well made. How often do you go to your surgeons when the person has a, high risk PE, because they're in shock and there's very little time sometimes to do things and they're crashing in front of your eyes?
So the problem is in our institute, we have a very good interventional radiologist who can do a catheter-directed embolectomy and catheter-directed thrombolysis, but we do not have a good CTVS support that can help us in doing surgical embolectomy. So we go to an IR specialist if we need to go for this catheter-directed therapies in our patient who is very sick, is having massive pulmonary embolism.
So very briefly, will you tell us about the catheter-directed therapies, please?
Sir, in catheter-directed therapies, we can do thrombolysis with there and directly where the femoral, the catheter is placed, and it is going into the IVCs and then directly into the pulmonary artery, and there up to the thrombus place, and there we can give the thrombolytic agents in a much lower dose as compared to the systemic anticoagulant therapies, and they can directly act there. Other things like ballooning of that clot can also be done, which can also help in maintaining the circulation of those arteries, removing the clot. And then surgical catheter-directed embolectomy and using ultrasound guided clot breakage can be also done using these catheters. So these are some ways in which our interventional radiologists can help us in with treating these patients who are who do not give us time before they are having high chances of mortality. So these things can be done.
Absolutely. So we do use catheter-directed treatments, and very often our vascular surgeons also, apart from our interventional radiologists, are able to do these catheter-directed suction of the clot, and that has a dramatic effect. But you've got to be careful. You've got to, choose the right person, and you've got to have your right technique of doing it. So it needs experience. Not everybody can do it. We fortunately have a very good cardiothoracic surgery team, and they are able to take the patient up immediately for a surgical thrombectomy. And so you have to explore all these. As Dr. Harjeet said, this is a multidisciplinary approach, and your PERT team can help you look after these patients much better and give you much better outcomes. My next question is going to Dr. Swapnil. You've decided on thrombolysis. How do you thrombolyze a patient? What agents do you use?
For thrombolysis, as in very high risk patient with cardiovascular instability, in our center, we commonly use recombinant tissue plasminogen activator. It has shown superior results as compared to heparin infusions, continuous heparin infusions, like with the MAPIT-3 trial. Other agents such as urokinase, streptokinase, we are not been using very commonly unless there are cost issues. But various trials like one is Gusto's trial where it has shown superior to urokinase, streptokinase also by 14. It is shown to reduce mortality by 14%, but at the expense of bleeding complications. So you need to choose a proper patients, and agents can be used as per the availability, cost, patient factors, etc.
And your familiarity with it. That's also so important. You need to be familiar with the drugs that you're using. Going back to, Dr. Preeti about this, how often do you use catheter-directed thrombolysis or thrombectomies?
So mechanical thrombectomy or the percutaneous catheter-directed thrombolysis, it is basically a newest modality depending upon the expertise at the center and the resources available, especially in the intermediate high risk as well as the high risk PEs. So here in the patients where the systemic thrombolytic therapy is contraindicated or the systemic thrombolytic therapy has failed, or the shock is to such an extent, as Dr. Aki already told, that we don't have that time that systemic thrombolytic therapy will act. In these kind of patients, we do these type of therapies where we can do, as Dr. Harjeet Tumra rightly explained, everything. We can have a thrombus aspiration, we can fragment the clots at the site, or we can distill the infusion of the thrombolytic agent, which would be of a lower dose as compared to the high dose which is being used in systemic thrombolytic use. So the chances of the bleeding, intracranial bleeding, is very low as compared to the high dose which is being used in systemic thrombolytic therapy. So these therapies are helping us as a bridge gap between the patients who are in a high risk PE and will certainly be of help whenever and however it is available.
Thanks, Dr. Preeti. When you have these patients on thrombolysis, your job doesn't end there. You've got to decide on anticoagulation. So, Dr. Bala, when do you start anticoagulation after you do a thrombolysis?
Yeah, just as Dr. Harjeet told, you generally try to stop anticoagulation immediately before and after the thrombolysis because the effects will last for some time. You can repeat the APTT after 6 hours, and then if it is more than 2 times the upper limit of normal, you can delay restarting the anticoagulation. And then when it comes below 2 times the upper limit of normal, you can restart anticoagulation. The safest one to restart at this point of time is heparin, unfractionated heparin infusion. You need not give the loading dose. You can start the maintenance infusion of 18 international units per kg per hour. And once the patient is hemodynamically stable and he is out of shock, in 24 to 48 hours, you can start the Dovac or warfarin as the case may be, and the patient can be continued on them.
Great. So you mentioned that you wanted to start anticoagulation initially with unfractionated heparin, which is the question I was going to come to Dr. Harjit. Dr. Harjit, you actually covered this, and I think, we don't need to spend much time on this, but unfractionated heparin, low molecular weight heparin, NOACs, which do you prefer? And of course, fondaparinux comes into the mix.
So if I've thrombolized the patient, I would still prefer to go with the parenteral anticoagulants upfront. This is a hemodynamically unstable patient. So just giving a thrombolytic will not reverse the shock right away. It takes a little while. And absorption of oral drugs or even subcutaneous heparin might be an issue. So if the patient is in shock, then an intravenous unfractionated heparin becomes the norm as far as absorption goes. If you have a stable patient, then I would prefer a low molecular weight heparin over an oral anticoagulant that far up front. I would reserve my oral drugs for maybe a few days down the line once I'm convinced that the patient is better and there is no issue with absorption.
Thank you. So I've just been told that there are 1,800 plus logins. So a lot of interest, and we'll keep this going for a little longer. But I think soon we should move to the audience questions. Quite a few have come in. I think some of these we've already answered, and some are going to come up in the question answer session. So I'm going to fast forward this and ask Dr. Bala, IVC filters, often a big, query that comes up. Vascular surgeons are very fond of it. What are the indications? What are the contraindications? And when do you say, I will not use a filter?
So we typically use IVC filter in a patient with acute proximal DVT or pulmonary embolism who have a definite contraindication for anticoagulation therapy, like recent surgery, hemorrhagic stroke, active bleeding, variceal bleeding, where in no way you can even give anticoagulation. And if we are using anticoagulation, putting an IVC filter, we should think that it is not the treatment of choice. It is a temporary measure because IVC filter may prevent a pulmonary embolism, but it increases the chance of deep vein thrombosis. It causes stasis of the lower limb venous blood. So, and we should, as soon as we are able to commence anticoagulation, the filter should be, IVC filter should be removed. The longer it stays, the longer it is difficult to remove, and the greater the complications.
For the record, previously we were not getting retrievable filters. Now we get retrievable filters. So always insist it should be a retrievable filter, and you want to leave it in as short a time as possible. As Dr. Bala has just told you, very few indications for an IVC filter. Really absolute indications, contraindication to anticoagulation or recurrent. You got a person on good anticoagulation, still there's recurrent disease. Or the person you've started anticoagulation, there is significant bleeding. The others are all relative or extended indications. We won't go into that, but I would say try to avoid filters unless absolutely necessary. And if you put them in, as he said, take it out as soon as possible. Extremely important that you don't leave it in for much longer. I'm going to stop with the last two questions because some of the other questions that I was proposing to ask have already appeared in the question answer. So we'll go to the audience for that. If a person, and this is a very important thing, Dr. Raki, if a person has hemoptysis, now we know hemoptysis can be a complication of, the pulmonary infarct itself. Do you anticoagulate? Do you not anticoagulate?
So this is a very difficult scenario. Like a patient we want to give them like anticoagulation, but if the patient is actively bleeding, that means that anticoagulation is not indicated at that time. So at that time, we need to stop our anticoagulation. First, we have to manage hemoptysis. If possible, if there's a bronchial arteries are tortuous and then we can find a bronchial arteries are bleeding, so we can go for a bronchial artery embolization in such patients. we can find out the cause. First we need to find out the cause of hemoptysis, and then we need to deal with that first. And once, like if the patient is having any history of recurrent pulmonary embolism, or there are like the Doppler suggestive of some like thrombus in the presence of DVT, then we can put IVC filters in such patients so that further pulmonary embolism does not occur till we are managing our hemoptysis. And then once the hemoptysis gets settled down, then IVC filters should be removed, and then we can start with our anticoagulation. So this is how, like,
I've probably given you the most difficult question, because honestly, when you're actually dealing with a patient, it is so difficult to decide. But as you said, the most important thing is try to identify the source of the bleed. And that's, I think, the beginning of all your things. And of course, before that, stabilize the patient before you do anything else. So good answer for a very tough question. And I think that is really one of the unanswered questions, even in the guidelines. Last two questions. Dr. Preeti, you have a patient who's got a cancer, and I think this is very typical of what Dr. Harjeet was telling us. These are patients with a high risk. So what anticoagulant do you use?
As per the guidelines, as of now, long molecular weight heparins are the recommended choice of treatment in cancer patients, effectively for the first few months and minimum period of 6 months. But there are problems with the duration. The patients cannot have subcutaneous injections at home. So now even the direct oral anticoagulants have been coming up, like edoxaban and rivaroxaban, which have been recommended also in the treatment of these patients. But initially we prefer that for the first time being, we give low molecular weight heparins, and then we can shift on the patients to these direct oral anticoagulants. And barring that, they should not have a genitourinary or a GI cancers where there is a risk of bleeding with these agents, and creatinine clearance to be kept in mind, which Dr. Hajidu has stressed in many points, that creatinine clearance has to be taken into account while we are using direct oral anticoagulants. So mainly for the treatment, we are preferring low molecular weight heparins still over direct oral anticoagulants, although they are coming up now and may be used as per the clinical judgment. And then we have to look at the bleeding scores and everything while we are have a discussion with the patient also, what would he prefer while we are treating those patients in a long-term basis, because the treatment can be extended as far as till the cancer is active. We have to extend the treatment. It could be more than 6 months or so. Then the patients who are on chemotherapy have thrombocytopenia or other side effects. There also we have to be taken care of, that we don't use these direct oral anticoagulants in those patients. So depending upon that, we make a choice in these kind of patients.
Again, a difficult choice very often, but we have to make it. And I think if we can train our patients to take subcutaneous injections, after all, they do it with insulin, it should be possible to keep them on low molecular weight heparins. And I usually prefer that, as long as the patient is willing to put up with it. And honestly, that's the least of their problems when they have cancers. So, they're going through so much more. I'm going to stop at this point. I think I was hoping to, take up some more questions, but on these questions, I'm going to invite any one of you to come in as soon as you have an answer. For example, the first question, I have no ability to treat children. And unfortunately, that's the first question that came up from the audience. Dr. Devkumar Jha asks, how can I suspect pulmonary embolism in a child presenting with respiratory distress with no pre-existing illness? So anybody here who has a lot of pediatric pulmonology experience? Any volunteers? I think all of us are adult pulmonologists. Harjeet, do you want to take that? Because this is punishment for wanting to run away soon.
So the question is that I don't think the presentation would be very different in a child as compared to an adult. The same risk factors apply to children. Maybe the anticoagulation dosages is something which we need to be more cautious about. Obviously, the trials have not included children as subjects in these trials. So I suppose for them, parenteral anticoagulants in a dose-adjusted manner would be the only norm. Diagnosis, I don't think the diagnostic algorithm is any different. If you suspect an embolism, the basic criteria will remain the same. The D-dimers are reliable in pregnancy and they are reliable in children as well. So I don't think there should be an issue.
Great. Thank you. I don't think anybody has a different answer. I certainly don't. I would completely agree with what Dr. Dobra said. Dr. Sami Jairam, who you know is very interested in sleep, he's a sleep medicine expert, asks, this is specifically for Dr. Harjeet, any OSA in your case with pulmonary embolic disease?
I wouldn't put that as a major risk factor, but OSA is never in isolation. 70% of your OSA patients are obese. Obesity itself is an intermediate risk for recurrent venous thromboembolism. And obviously the comorbidities with obesity are also risk factors. So yes, in any group of patients, there would be obese patients who would end up getting embolisms. But I wouldn't pinpoint OSA as directly connected to a hypercoagulable state unless and until it is an obese OSA. That is the only link. So, but me in particular, I have not been able to find that particular link between OSA and embolism, but obesity and embolism, yes, very much so.
I think there are some isolated reports, nothing very strong, no very strong evidence. One of my residents is doing an additional paper, not her thesis, on looking at OSA in all our patients with pulmonary embolic disease and trying to find out how it is. So that we may have to wait a little while for that answer. I think Dr. Raki was nodding. So do you want to add anything to that, Dr. Raki? You're muted. Can you unmute, please?
So I was thinking that it was such a nice, like if the results comes out, it might have a nice correlation. If that is why I was not.
Yeah. So I think we will come up with that. Hopefully, we get enough evidence to publish a positive or a negative test. So Dr. Amina Islam asks, what is the diagnostic modality in pregnancy? Dr. Bala, you want to take that? In pregnancy, or Dr. Swapnil?
Yeah, so in pregnancy, the clinical suspicion and the risk stratification still holds true. D-dimer can be elevated in advanced pregnancy. So D-dimer per se alone cannot be relied on for ruling out pulmonary embolism. The two things which we can do in each and every patient with suspected pulmonary embolism is a Doppler scan of lower limbs and echocardiography with no risk of radiation. So you can subject them to an DVT screen as well as to see any evidence of pulmonary embolism, massive pulmonary embolism on echocardiogram. If it is there, then you need not do CTPA or VQ scan to prove pulmonary embolism in appropriate clinical scenario. In the absence of this, then it becomes tricky. We have two modalities, VQ scan and CT pulmonary angio, and both have differential radiation exposure to the fetus as well as to the mother's breast. CTPA is very good, but it has high radiation exposure to the mother's breast. The VQ scan does not have as much exposure to the breast, but it has exposure to the fetus. So overall, earlier people used to say that VQ scan is safer considering the mother's future cancer risk, CA breast risk in consideration. But we need to remember that if patient has a cardiopulmonary disease, then VQ scan is not the modality to do. You have to go for CT pulmonary angiogram. You cannot do a VQ scan if the patient has underlying past history of pulmonary disease or heart disease. You cannot rely on that. And we have to remember that a healthy mother is most important in this scenario. We have to confirm the diagnosis and treat it. It has an implication in it. So when the patient's life is at risk, you go ahead and treat, and then when facilities are available, whatever modality comes, you use them to bring out the best outcome for the mother, followed by the child. So
Excellent.
There is not much to differentiate in that critical situation.
But be very careful, because breast cancer risk is there for any CT procedure involving the chest, but especially in pregnancy, the risk rises. So that's something to keep in mind always. But the immediate welfare of the patient cannot be sacrificed for some future theoretical risk. So I think that was excellently put by Dr. Bala. Dr. Ramya asks, is there any treatment protocol like heparin 6th hourly rather than heparin infusion? Dr. Swapnil, you want to take that? Heparin 6th hourly versus heparin infusion, which would you prefer?
There are only, as far as I remember, there are very few trials which mentions difference in infusion, either prolonged infusion or bolus infusions. And most of the data is prefer giving it as a continuous infusion. I feel. If, correct me if I'm wrong, sir.
I would agree. Anybody has any other opinions? I think the important thing is make sure you're getting to the target APTT. That is really the critical thing. So in our ICU, certainly we always prefer to start with a heparin infusion because you can be much more flexible with your adjustment of it. Right. Dr. Mohit Kaushal asks, what cutoff of D-dimer would you describe? I think Dr. Harjit has covered that pretty well. There was a recent paper which suggested that a D-dimer of 1,000, it virtually always will tell you that there is, in the absence of any of the confounding factors, tells you that there's a very high chance you're dealing with pulmonary embolism in the appropriate pre-test scenario. But 500 is the usual cutoff that we use. But again, you've got to adjust it according to age. That's very, very important. Dr. Tridib asks, do you use BNP to decide on thrombolysis versus low molecular weight heparin as a treatment in moderate PE? I think that we've answered, isn't it? We've said high risk versus intermediate high versus intermediate low. And one of the factors that we use is the BNP or the NT-proBNP, along with troponin I, something to tell you that the myocardium is getting strained or damaged. So if you have one of these biomarkers with echo evidence in the background of a PESI score, then it becomes high risk, intermediate high risk. If the BNP is normal or one of these biomarkers is normal and only one of these three is positive, then it becomes an intermediate lower risk. Again, Dr. Tridib asks, urokinase versus alteplase as treatment for financial reasons as thrombolysis. I'm going to go back to Dr. Swapnil on that.
As we discussed, whichever you are comfortable, and considering patient's factors, cost factors, we need to go ahead with the thrombolytic agent, the choice of the thrombolysis agent. So if cost is an issue, definitely, then there is no other option. You have to go ahead with urokinase.
Absolutely. So I think the important thing is to get a thrombolytic agent in. And cost, of course, is going to play an issue. Keep that in mind. We can't put the patient through, something very expensive because the treatment.
Addition to that answer. So if I may.
So please.
Cost issue can be can be dealt with the newer agents like retiplase and tenecteplase. Tenecteplase has some data and approvals as well. Retiplase has not got that approval, but these are cheaper thrombolytic agents where we don't have comparative data against urokinase and streptokinase. But considering that we have data that alteplase and tenecteplase is almost has similar efficacy, you can extrapolate that tenecteplase and retiplase would be cheaper but equally efficacious as an RTPA. And RTPA is superior to urokinase and streptokinase when you look at the risk-benefit profile. It's always bleeding risk versus efficacy. And the reason we choose TPA is because the risk-benefit ratio is the best. In fact, tenecteplase has better efficacy than alteplase in some studies. But the bleeding risk of tenecteplase is higher than alteplase. And that's why when you combine the risk-benefit, TPA scores over tenecteplase. So tenecteplase and retiplase can be cheaper options.
So we usually use tenecteplase actually, except when the bleeding risk is high. When we, your assessment is high of a bleeding risk, then we go to RTPA. And then very often you use the half dose with as shown by the MOPET. Dr. Tridib again asks the duration of NOACs in patients with pulmonary embolic disease. Anybody wants to take that? I think Harjit has already answered it to some extent. Yeah, Dr. Preeti, go ahead, please.
Yeah, duration will also depend upon the provoked or unprovoked PE basically, and depending upon the risk factors, whether they were transient or still existing. So depending upon that, duration would be like initially for unprovoked, we have to give it an indefinite treatment that is lifelong most likely. And then if it is a provoked, then the risk factor has to be weighed. If it is after a surgery, how for a few weeks to months, that is 3 to 6 months after any kind of other factor which has gone now. So we will
Absolutely.
continue.
So previously we used to use, after stopping the anticoagulation for a month, we do the D-dimer. And there was a reasonable evidence that will predict the chance of a recurrent PE. Now I think the VT predict is also a very good marker. And I think I would really like to combine both, because the risk based on the underlying risk factors is so important. You cannot afford a recurrent PE. One of the things we found, as you know, we do a lot of CTEF, patients. We see a lot of CTEF patients. Recurrent PEs are what are more likely to cause CTEF, and I'll come back to this later. Dr. Harjit, you wanted to add something else?
So the duration of anticoagulation is based on too many factors. It can never be just based on one. And it's a very individualized decision. The foremost being discussion with the patient about the risk. So a 25-year-old female or a boy giving an anticoagulation for years together without justification is not easy. So this discussion is very important, and it is revisited every few months to a year. So I have to really counsel them every year that this year, would you like to stop or would you like to continue? Because it's very difficult when the recurrence rate maximally, even with cancer, goes anywhere between 10 to 30%, and thrombophilia risks vary between 10 to 15%. There is an 85% probability you will never develop a recurrent VT, which becomes not a thing.
And you do your little bits of, taking care if a person is in bed, if a person is dehydrated, what things you do, so add that on in your discussion. That's all I'd say. Right. Dr. Rabita asked, interesting question. Again, I think I'll go to Dr. Bala on this. Dr. Balmukesh, what should be the approach to a patient who's already on prophylactic heparin and develops tachycardia, hypoxia with hypotension, and a PE is suspected, but a CTPA is not readily available? So lots of caveats there. CTPA not available, patient is on prophylactic heparin or prophylactic anticoagulation, now develops a feature suggestive of a pulmonary embolism, but basically tachycardia, hypoxia, hypotension.
In the absence of any other obvious diagnosis, you consider this as a pulmonary embolism and you increase the dose of anticoagulation from prophylactic to therapeutic. So if you have just given prophylactic dose of 40 milligram of enoxaparin, you calculate the therapeutic dose and give the added dose immediately to that patient. And in the absence of CTPA, all is not lost. You have other armamentarium like you can do Doppler of the lower limbs, you can use echocardiogram, and if the patient is not previously known to have pulmonary hypertension and echo shows a new onset of pulmonary hypertension, you have the diagnosis. You continue therapeutic anticoagulation, stabilize the patient, and once patient is stable, you find out where you can confirm the diagnosis by doing a CTPA.
Absolutely. And of course, make sure that is the most likely cause and the person is not bleeding. The person is already on anticoagulation, maybe bleeding, which can again cause the very same symptoms. So be careful about that. I think Dr. Mohit Kaushal has asked a very interesting question. I'm probably going to go to Dr. Raki on this. Do we need to give rivaroxaban or apixaban twice a day for the first few days, usually 21 days, if already given low molecular weight heparin for the first few days? So you're converting from low molecular weight heparin to either apixaban or rivaroxaban. Do you give a higher dose in the beginning and then scale it down?
Sir, if we are not using a low molecular weight heparin in the initial days, then yes, we do give twice a day. But if we are already used it, then we can give a higher dose once daily, like rivaroxaban 20 mg once daily, if we have already given low molecular weight heparin in the initial setup.
And the usual time you give it is when the next dose is due of the low molecular weight heparin. But I honestly don't know the answer to that. Does anybody else have any other opinion? Would you give the higher dose in the beginning and then scale down to the maintenance? It's a good question. I honestly don't know the answer to that. I was trying to read while we were talking, and I think
It is
even the
mentioned
literature
in
is
the
quiet.
guidelines that we give rivaroxaban twice a day for 21 days. So depending upon
Exactly.
how long we have given low molecular weight heparin, so we can continue with that higher dose for twice daily for
For the
first 3
remaining
weeks.
period. Good
In
point.
the
I think that
and then
sounds,
we can continue
fine.
with the once daily dose.
So
Absolutely.
one thing which you need to understand it, this twice daily dose is not like a loading dose. So it's just that upfront you want maximum anticoagulation, and down the line you can maintain it with a lower dose. It's not that it's a loading dose. So if you're substituting from heparin to a DOAC, you don't need a loading dose. It can just be substituted when the next dose is due. So it need not be the higher dose upfront. Secondly, the trials were designed in that way where you had to give heparin because these trials were the first few trials of DOACs. So they didn't want to take chances in a patient of high-risk embolism. And then that is why they started with heparin upfront, followed by DOACs. But by the time they got to apixaban, that they had experience. So apixaban can be given upfront in the oral form without heparin also. And again, the same principle applies. It's not a loading dose. It's just that upfront you don't want to take a chance with the levels.
But you've got to give it for a certain amount of time to ensure that, you've got adequate. Yeah. So I think, the point Dr. Preeti made was sensible. 2 weeks, 3 weeks, whichever you're giving, complete at least the 3 weeks, and then you can scale it down. Clot burden, Dr. Aniket Mondal asked, what is the significance of clot burden on CTPA reporting? The radiologists are very fond of that. I don't think there's any evidence that it has, any predictive value. You would much rather go by the risk stratification that we've already spoken about. Some cardiologists, our very senior cardiologist, Professor Cherian, believes that if you have a clot burden greater than 50%, the Canadley clot score, then you have a higher risk of going on to chronic disease because you don't, the clots don't resolve that quickly. No definite evidence for that.
Few
Anybody
studies
wants
mention that few studies mention that it correlates with the RV dysfunction.
Exactly. So that is why the RV dysfunction, picking it up is more important, which an echo will do with great efficacy. So Dr. Jayaraman again says, Dr. Harjeet, thank you for a crisp and in-depth presentation. Multiple subsegmental emboli seen on CTPA, how long to continue anticoagulation? I don't think it makes a difference. If it's chronic, then it's lifelong. COPD patients, how common do we suspect in COPD? I think the Rome, suggestion is that you suspect it in every patient. And as I think Dr. Preeti mentioned, about 10% of patients with acute exacerbation of COPD actually have, repeated studies have shown that, have acute Ps as the as the cause. I am going to go fast through that because we have just a minute or two to go. Rows of surgical, we are not going to go into CTEF. 2 people have asked about Riociguat and surgical treatment. We are not considering that at all. Dr. Haresh, and I think he's asked it twice, what way can we diagnose in case of renal failure? And clarifies, the creatinine is high, VQ scan is not available. How do we prove? I think we've just discussed it. There are various surrogates that we can use. Go by your clinical suspicion and make a diagnosis. I'm going to stop at this point. Thank you. We've had a brilliant discussion. Initial great talk by Dr. Harjeet Dumra and all panelists contributing brilliantly. I've been so impressed with the quality of the answers that we've had. I'm going to go to each of our panelists with one line statement before we close, starting with Dr. Swapnil. One line, acute pulmonary embolism, take home message from you.
So get your clinical suspicion, get your clinical examination and history properly, and stratify the risk, and then go ahead with the investigations.
Great. Dr. Bala?
Think about pulmonary embolism as a differential diagnosis of any undiagnosed pulmonary condition, because you might be surprised that it is actually pulmonary embolism which was missed.
Absolutely. Very high suspicion, very important, especially based on persons with risk factors. Excellent point. Dr. Preeti?
Yeah, just go through the basic guidelines and do not jump to the fancy tests, and just be with the first risk training and then go ahead with the diagnosis and the basic treatment as per the guidelines.
Well said, because I think the guidelines are based on good evidence. And remember that they're being constantly revised as evidence accumulates. Just don't go by only gut feeling. The gut feeling is useful for your initial assessment, and then start applying the scores that we know about. All the scores are available or free on the net. You all got your smartphones. Just go to these 3 or 4 scores and you can assess them. Dr. Raki.
So since it causes a high incidence of mortality, and it is one of those causes in which death can be avoided, so we have to be on our toes when we are suspecting acute massive pulmonary embolism, and try to save the patient as much as as early as possible.
And get the help of your colleagues, because this is a multidisciplinary problem. I like always this sentence that was, I start a lot of my talk with. The pulmonary circulation lies between the territory of the cardiologist and the pulmonologist and is understood by neither. So, that is something we need everyone's help, including the radiologist. As I think somebody pointed out, the PERT team did not include the radiologist. It was such an important part of it. We started with Dr. Harjeet Dumra. We will end with Dr. Harjeet. Harjeet, thank you for staying on. I know you have an early morning flight. We'll let you go after this, but a closing comment from you.
Right. So from me, it is always prevention. It is the single most important preventable cause of mortality in hospitalized patients. So you need not deal with all these complications if you prevent it well. So always, always, always use DVT prophylaxis. Like I ended my talk, it's always the most emphatic thing which I would like to put across.
Absolutely. I think that's a brilliant way to end. Prevent a PE before it occurs. So important. I'm going to stop. Thank every one of our panelists for this absolutely excellent discussion. Thank audience for being so enthusiastic. 1,800 plus logins. Most of you stayed till well after 10. Most grateful to you. Thank you to the ICS, Dr. Abita Nene, especially for bringing us all together. Dr. Raja Dar and Dr. Sandeep Salvi. Thank you for inviting us, and we're always there to support you in any of your academic discussions. And when we talk about support, we cannot forget excellent tech support. So thank you, the tech team, Aditya, Rohan, and others for taking us through this. Stop at this point, and good night, everyone.
Good night. Thank you, ICS, and thank you, sir, for such a beautiful moderation. That was really brilliant.
Rohan, you can stop